Types of causes of hypoxia. No? 4 types, all of you know. But, anoxic, anemic, and stagnant, and histotoxic. Histotoxic is not a very common thing that to happen, but these 3 are very common. Hypoxic, anemic, and stagnant causes are the most common causes for that. And it can occur in the pre, intra, or post-op period. The pre-existing medical conditions like pulmonary diseases or cardiovascular diseases or uncorrected or undetected anemia. Obesity is also one of the important causes for both pre-op and intra-op, especially patients if they have sleep apnea. They are more prone to have this. So we must identify patients who are likely to become hypoxic both during induction and intraoperative period, or patients who have airway diseases or issues like proximal airway obstruction due to laryngeal edema, foreign body, inhalation, or tumors. This is more common in as an emergency in the toddler age group of pediatric patients, or this may be because of anaphylaxis and where laryngeal edema can happen, or pre-existing airway tumors. They all can cause partial obstruction in the proximal airway, or distal airway obstruction, which can happen in bronchial asthma, COPD, or excessive secretions, which happen in cystic fibrosis and other conditions. And patients who are likely to have a difficult mask ventilation and intubation because of distorted facial anatomy like Perioperarive syndrome or pressure collar syndrome, or in facial trauma where there is a disruption of the normal anatomy. In all these patients, we have to anticipate preoperative hypoxemia, or it may be complications during pre-oxygenation, which we cannot control properly. And patients coming for emergency surgery, where there is inadequate time to prepare the patient properly. They may, for example, a patient with distension of abdomen because of injury or intestinal obstruction, they may have a restricted movement of the diaphragm, and he may be hypoventilating. So, and we don't have time to wait and correct all these things, and patient may land up with the hypoxemia during induction. Similarly, geriatric patients who have a knee dentless jaw, where trying to give a jaw thrust or a chin lift may cause more occlusion, as I have shown earlier in one of the first pictures. So these are all the pre-op causes which we have to be very aware of cause of hypoxemia. Now, coming to the intraoperative causes, they can be classified as A, B, C, D, E. And A because of obstructed airway problems, B because of the breathing circuit and breathing devices problem, which usually either can be equipment problem or it can be because of the occurrence of pneumothorax or pulmonary edema, lung related problem, or a high spinal producing muscle paralysis and inadequate breathing, and circulatory problem like sudden hypotension or abnormal heart rhythm and cardiac failure or sudden cardiac depression. All these things can lead to hypoxemia. And several drugs can be the cause: deep anesthesia, depressing both the respiratory and the cardiovascular system, and drugs which cause sudden hypotension, like your induction agents, especially in the elderly or hypolimic patients. When you give induction agent rapidly, that will lead to hypotension, which may again lead to hypoxemia. And muscle paralysis not correctly reversed, the patient having inadequate power to breathe, causing ventilation leading to hypoxemia. and anaphylaxis of some drugs, especially drugs like atracurium, they rarely can produce anaphylaxis, release the bronchospasm, which lead to uh, hypoxemia. And of course, all the equipment problems like leak and cylinders not being checked. All these things are more or less some of the iatrogenic problems which we uh, discussed in the earlier slide. And so these are all the reasons why these things happen, especially the atelectasis, absorption atelectasis, diffusion defects, and etc. And at the level of the delivery of oxygen from the equipment, you can classify them at the circle supply level, pipeline distribution, windows, the various problems at the anesthesia machine level, anesthesia ventilator level, anesthesia tube level, and ET tube level. So like that, you can classify the equipment category of producing anesthesia as a hypoxia. Then post-op anesthesia and surgery-related factors are respiratory depression, especially after opioid anesthesia and GA, inadequate muscle power due to inadequate reversal or reperiorization happening, opioid overdose or sensitivity, abdominal compression due to binders and other restrictions in the movement of diaphragm, and pulmonary dysfunction either due to atelectasis, ventilation perfusion mismatch, bronchospasm, pulmonary edema, pulmonary embolism, or pre-existing like asthma and the COPD, where patient might have had a low oxygen even in the pre-existing level. So if a patient has a CO2 of 90 or 92, the pre-anesthetic situation with a patient with a COPD, if you have the same 90 or 92, you should be happy with that. You don't have to consider it as hypoxemia and treat it. On the contrary, room air saturation is 90, 92, and post-op it is 75 or 80, definitely they should. So that sort of distinction we should be able to make between a real hypoxemia and a disease-induced normal hypoxemia, which is consistently present in those patients. And the other factors can be hypovolemia, hypotension, shivering, pain, etc. And the normal mechanism can on this slide I thought will be useful. It can be due to lack of alveolar ventilation, lack of perfusion in the alveoli, and decreased alveolar diffusion. So lack of ventilation will be due to airway obstruction or respiratory depression, pneumothorax and atelectasis and bronchospasm. These are all the causes for lack of alveolar ventilation. And perfusion usually is affected by pulmonary embolism, which is quite rare. And decreased alveolar diffusion can happen in patients who have already have pneumonia, ARDS, or pulmonary edema. In these cases, the hypoxemia will happen because of the failure of diffusion. And treatment, provide supplemental oxygen. That is the first and foremost step. Irrespective of the cause, first start with the supplemental oxygen, especially high flow nasal oxygen, and correct the underlying cause. There are so many causes which we have described, and use non-invasive ventilation techniques if needed. Oxygen supplementation can be given via nasal cannula, face mask, high flow nasal oxygen, and our therapy should be titrated to keep the levels above 90%, and giving too much of oxygen for too long is also not good. So you have to be careful in administering 100% oxygen for too long a time, and identify the cause of hypoxemia and correct it. And if it is atelectasis, encourage deep breathing, incentive spirometry, and DIB mobilization. It is pain, provide good analgesia, especially with the regional techniques, so that patient can take deep breath and clear the secretions by coughing. Residual neuromuscular blockade, consider adding more reversal agent or supporting the ventilation until the patient regains normal power. Suction the airways to clear all the secretions. always preferable to give about 20 to 30-degree head up tilt so that the descent of diaphragm will be uh, normal so that patient can breathe easily, especially in obese patients. They recommend the patient to be almost in the sitting up position before extubation and then the post-operative period. And fluid management, make sure that they are having adequate circulation, and hydration will also help to loosen any thick secretions which have formed in the respiratory tract. And non-invasive ventilation like CPAP and BiPAP may be considered to the patients who are consistently hypoxemic. And the effective management of perioperative hypoxemia is a collaborative effort between the anesthesiologists, surgeons, and respiratory therapists and nurses. So it is not only our job, but also the surgeon should indicate correctly by they can help by releasing the tight bandage in the abdomen, especially after laparotomy, and the nurses should be able to help the patient with the positioning and encouraging deep breathing, all those things. So it is a multidisciplinary effect increasing the concentration. Right. You are presenting.